Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
So here's our game plan. We'll start with the urogenital blueprint, tracing everything back to its origin. Then we'll look at the temporary kidney systems the body builds before we get to the main event, the permanent kidney. After that, we'll cover the plumbing, the bladder and ducts. And finally, we'll tie it all together to see how this developmental story makes sense of common birth defects. Okay, first things first, we have to start with the most fundamental question in all of embryology. Where does this system even come from? What's the source? The entire story of the urinary system kicks off right here, with the intermediate mesoderm. Around the third week, this strip of tissue forms a long ridge called the nephrogenic cord. And this cord, well, it's basically the wellspring for almost everything we're about to talk about. And this image really helps you visualize what's going on. You can see the paraxial mesoderm in the middle and the lateral plate mesoderm off to the side. But right there, sandwiched between them, is our tissue of interest, the intermediate mesoderm. See how it bulges out? That forms the urogenital ridge, which is the shared precursor for both the urinary and genital systems. Now, this is fascinating. The body doesn't just build the final kidney in one go. Instead, it creates a series of 3 overlapping kidney systems, one after the other. You can think of the first 2 as temporary prototypes that pave the way for the final version. Okay, this timeline is absolutely crucial. You have to understand that in embryology, timing is everything. First up is the pronephros, which shows up in week 4 and is gone almost as quickly. It never really does anything. Then comes the mesonephros, which actually works for a little while. But starting in week 5, the real deal, the metanephros, our permanent kidney, begins to form. Any hiccup in this sequence can lead to major problems. And this is a great visual to show a key shift in how things are built. Up in the neck region, the intermediate mesoderm is segmented into these little blocks that form the pronephros. But as you move further down the embryo, that segmentation disappears. The tissue becomes this unsegmented mass, the nephrogenic cord. And it's this cord that gives rise to both the mesonephros and, later, the metanephros. So let's talk about the mesonephros. Think of it as version 2.0. It's more advanced, it actually forms glomeruli, and it produces a little bit of urine for a few weeks. But honestly, its most important contribution isn't making urine. It's the duct it creates, the mesonephric duct, also called the Wolffian duct. This duct is a major player, not just here, but especially in the development of the male reproductive system. All right, now we get to the main event, the formation of the metanephros. This is our permanent, lifelong kidney, and its development, starting around the 5th week, all comes down to a precise interaction between 2 completely different tissues. Okay, if there is one thing you take away from this entire discussion, let it be this. The permanent kidney has 2 separate origins. You have the metanephric blastema, which comes from the intermediate mesoderm, and it's going to form all the nephrons, the filtering parts. Then you have the ureteric bud, which is actually an outgrowth of that mesonephric duct we just talked about. This bud forms the entire collecting system, all the plumbing. Understanding this dual origin is the key to everything. Everything, and I mean everything, hinges on these 2 tissues talking to each other. The ureteric bud grows into the metanephric blastema. And this kicks off a molecular conversation. It's a classic example of what we call reciprocal induction. The blastema tells the bud to grow and branch. And in return, the bud tells the blastema to turn into nephrons. If this conversation doesn't happen, you don't get a kidney. Simple as that. So once it gets the signal from the blastema, the ureteric bud starts this incredible process of branching over and over again. The initial stalk becomes the ureter, the tip expands to form the renal pelvis, then it splits to form the major calyces, then the minor calyces, and it keeps going until it's formed millions of tiny collecting tubules. It's literally building the entire plumbing network from the ground up. At the same time, the metanephric blastema is listening to those signals from the branching bud, and it gets to work. These little caps of tissue over the tips of the collecting tubules form vesicles. Those vesicles then stretch out into S-shaped tubules, and those become the functional parts of the nephron. Bowman's capsule, the convoluted tubules, the whole works. Finally, it fuses with the collecting duct, connecting the filtering part to the plumbing part. Here's something you might not realize. The kidneys aren't built in their final location. They have to go on a journey. They start way down in the pelvis, and then as the embryo grows, they ascend up into the abdomen. While they're moving up, they also rotate 90 degrees inward, so the hilum faces the midline. And to get this, as they ascend, their blood supply constantly changes. They get new arteries from the aorta at higher and higher levels, and the old lower ones disappear. Okay, so our kidneys are built and they've migrated into position. But now what? We need the plumbing. We need a place to store the urine and a way to get it out. And this story starts with a very primitive shared chamber. You have to picture this. Early on, there's no separate plumbing for the urinary and digestive tracts. Everything, the gut, the urinary system, all empties into this one common chamber called the cloaca. The name literally means sewer, which gives you a pretty good idea of its function. So obviously, this can't stay this way. A really critical process called septation has to happen. A wall of tissue, the urorectal septum, grows down and divides the cloaca in two. The front part becomes the urogenital sinus, which will form the bladder, and the back part becomes the anorectal canal. If this division fails, you get some very serious clinical problems. Now, this looks complicated, but it explains a piece of adult anatomy perfectly, the trigone of the bladder. See, at first, the ureters branch off the mesonephric ducts, but as the bladder grows, it actually absorbs the ends of those mesonephric ducts into its own wall. The result? The ureters end up opening separately and higher up on the bladder, while the mesonephric ducts get pulled down lower. It's a really elegant solution. All right, this is where it all comes together. Let's see how this developmental story directly explains common problems you'll see in the clinic. Because every anomaly is just a story of development gone wrong at a very specific point in time. Just look at this table. Every one of these anomalies is just a developmental step that went wrong. Renal agenesis, the absence of a kidney, that means the conversation between the ureteric bud and the blastema never happened back in week 5. A pelvic kidney, that means the kidney started its journey upward but never finished. A horseshoe kidney, the two kidneys fused at the bottom while they were still in the pelvis and then got snagged on the inferior mesenteric artery during their ascent. Once you know the story, these conditions are easy to understand. Now, here's a concept that might surprise you, but it's clinically vital. Fetal kidneys aren't for cleaning the blood. The placenta takes care of all waste exchange with the mother's circulation. So what is the fetal kidney's most important job? Making amniotic fluid. And that's because by the time we get to the second half of pregnancy, most of that amniotic fluid is actually fetal urine. This is why if a fetus has bilateral renal agenesis, no kidneys, it's a catastrophic problem. No kidneys means no urine, which means almost no amniotic fluid. This condition, called oligohydramnios, means the fetus is compressed, and crucially, the lungs can't develop properly. So, to wrap things up, this whole complex journey, from a simple strip of tissue to these temporary prototypes, all the way to a migrating, rotating organ that talks to its neighbor, it's not just a collection of facts. It's a logical framework that explains both the elegant design of the adult kidney and what happens when that design process goes awry. So I'll leave you with a question to think about. How does this whole story we just walked through explain why about a quarter of all adults have extrarenal arteries? Well, think back to that journey of ascent. The kidneys get a temporary blood supply from arteries at different levels. Accessory renal arteries are simply those temporary, lower vessels that forgot to disappear. Understanding these connections is what separates memorizing facts from truly understanding anatomy.